I know they're not driving, sometimes that means bringing them a little surprise. And then they had a drink to me.
Brought to you by Smart Serve Ontario and Arrive Alive, Drive Sober.
This program is brought to you by Rogers Xfinity, connecting you to more of what you love. Visit Rogers.com for more details.
Hello and welcome to HealthLink, a program connecting home, community, and healthcare. My name is Carol Merton, and today I'm delighted to welcome two guests to the program. In no particular order, Annette Pedlar, who is the Executive Director of Safe and Sound, and Lindsay Johnston, who is the Director of Implementation, Ontario Health Team, Grey Bruce. Hopefully I've got all those titles right. And we're going to talk today about a topic, palliative care and end-of-life care for the unhoused, precariously housed, or homeless. I want to welcome you both and thank you for being on the program. I have to be honest, Annette told me that this was going to be a winning program because it was an important topic, and that was in June. So we're here today for a winning program about a very serious and sensitive topic. I have to be honest, it caught me off guard. You know, we talk about the unhoused and meeting their needs for survival, but end-of-life care and palliative care is something that I think deserves a very critical look for those who are obviously our marginalized population. So thank you both. I have so many questions. I hardly know where to begin, but who would like to start? Like, how much of an issue is this, and what are the barriers? And what is the Ontario Health Team? Like, how did the Ontario Health Team get involved? Told you I had a lot of questions.
It sounds like you better start, Lindsay.
Yeah, so I'll give a little bit of an overview of how we got to working on this project. So about a year ago, a call for proposals came out from Healthcare Excellence Canada for a project that they actually started 2 years ago. So they were doing a call out for the second cohort of applicants. And the name of the project is Improving Equity and Access to Palliative Care. And it's to focus on improving access for priority populations, specifically people who are Indigenous and those who are unhoused and vulnerably housed. Mm-hmm. And it's it's an unfortunate statistic that individuals who are vulnerable and marginalized really have extremely poor access to palliative care, and at very disproportionate ratios to what many privileged individuals experience. So this palliative care is one of the priority populations of the Ontario Health Team, and I've been very fortunate to work with the Grey Bruce Palliative Medicine Group, who are an extremely engaged group of physicians that really want to improve access to palliative care for the entire region of Grey Bruce, and especially populations that are underserved. So we put in a proposal. I worked very closely with Dr. Kelly Fenn, who is a lead on this project and very passionate about this subject. And we were successful in obtaining the funding for this. And really, when we put in the proposal, it was just kind of defining the need. And, we know the need's very high in Grey Bruce. We don't have any service really for individuals in these priority populations that really provides kind of low barrier access to palliative care. And so we started by, bringing a group of partners together, and, a group that I hadn't previously worked very closely with, and it's been a really, really great experience for me, and I know for the entire group, getting to work closely with Annette and many others who are day to day working, on the front lines with individuals who really need better access to care. So that's a bit of the history of how we got here and working on this project. And the first piece of it is really a needs assessment. So looking at what is out there currently. Where are the barriers, and what could we do to reduce those barriers and get individuals the care that they need? And the other thing is, what does palliative care look like for individuals who are unhoused and vulnerably housed and really been let down by our healthcare system. So I don't know, Annette, what you would like to add to that? I feel like I talked for a while.
Yeah, no, I think that I'm the same way, Carol, that this kind of got me right between the eyes when I first heard about it. And it's not something that I had spent a lot of time or had to spend a lot of time thinking about. And I think because of the understanding that right now palliative care is often it's a privileged thing for people to be able to access, and also because so many of our folks and participants, the barriers to accessing medical care before mean that they might not necessarily even know or be in a position to take on the knowledge that they are themselves would be benefiting from palliative services. So I think that for me, a lot of the learning about this has been about trying to understand that palliative care isn't just hospice, and that there's a lot more service and supports that can be integrated into people's lives, even if it's not like somebody who's expected to die in the next couple weeks. I think that Dr. Fenn shared that there's 2,000 people who pass away every year in Grey County. Was it Grey County or Grey and Bruce?
Grey Bruce, yeah.
Grey Bruce. And out of that, I think it was 1,800 would die in a protracted manner, and therefore could benefit from some form of palliative services. So I don't think that 90% of the population who pass is maybe reflective of exactly a lot of the homeless and marginalized communities, because a lot of those deaths come a lot more quickly and a lot maybe more violently or harshly, and just the broad understanding of violence. But I think that it's really it's definitely a stat that I did not recognize and understand before.
Yeah. The other component is around, you mentioned about supports, and certainly that will be helpful to talk more about during this program. But often those who are unhoused may not be connected to their community. They may not have family supports for various reasons, that those who in more privileged situations automatically have that infrastructure and that surrounding caring network. I'm assuming this puts our marginalized, vulnerable people at more risk of challenges. Maybe you could speak a little bit about some of the supports that could be available for those who don't have what we would consider other types, and also how long the project's going to go on for, and if you could fill us in a little bit about that, please.
Yeah, I'll just start with some of the services that Save and Sound offers, just because that's where I'm sort of sitting in the system. So we try and connect people. We have the SOS team. So for anyone who doesn't know about SOS, it's a fantastic program, an initiative that's got a lot of different supporting partners. So there's 2 mental health counselors from Canadian Mental Health Association. There's a nurse practitioner from the hospital Hospital, as well as fantastic paramedics from Grey County, as well as a social navigator who's a finder and fixer of many things from the United Way. And so we're really, really privileged to have that team who has a once a week clinic at Safe and Sound every Tuesday afternoon. And so that's typically a first point of entry for a lot of our folks who are needing to access different medical care. And of course, the emergency room is a big piece also. I think that one stat that I just kind of want to go out of my way maybe to bring up is the having those supports though that aren't the emergency room is really, really important. And we saw that last winter when Safe and Sound became 24 hours. Over the same 5-month period from the previous year when we weren't open overnight to when we moved to a full 24-hour drop-in service, there was 71 less emergency room visits to the Owen Sound Hospital during that time. So there are ways that these programs and initiatives can help our already stretched and at capacity hospital system. And I think it's important for people to see all of the different points of value, and that if you don't think that this is impacting you, it is, because it's impacting your ability to access care in a rapid way. If other folks are needing to access it because they have exposure related conditions, or and they have to be admitted to care to hospital. Yeah,
For sure. So Lindsay, how long is the project, and what are some of the barriers that you've identified so far?
Yeah, for sure. So this project actually runs until 2026. So we have quite a bit of time. The funding flowed in April, so of 2024. So it'll extend until April 2026. And we, our goal, as in all of our projects, is to create something sustainable. That will either be, that we can prove is effective and really serving the need, and then we can find a way to continue funding it and providing the resource. So I just to build on what Annette said, for a lot of the privileged individuals in our community, if you're receiving palliative care. So, that can be, it's not right, doesn't mean hospice. If you're seen to be requiring a palliative approach to care, requiring, treatment for pain and symptom management and improving quality of life, and you're in a home, you have access to, home care nursing and PSW support, and a lot of services that are really dependent on having a home. And the same for kind of hospice. Hospice, I'm not sure if you've ever visited Chapman House. It's a gorgeous, gorgeous facility, but it's not always the most welcoming place for everyone. Especially individuals who haven't had the best experiences in institutions in the past, such as hospitals. They tried really hard to make it not look like a hospital, but it still has that, that appearance. And so I think what we hope to be able to do is create referral pathways and, some sort of program that individuals who are identified either in the community, like hopefully it doesn't have to be through the ED, like Annette mentioned, like hopefully it can be referrals from Safe and Sound and from, caseworker, housing workers, and other individuals, the SOS team, to, create pathways that individuals who would really benefit from a palliative approach to care are able to access it. And that's, accessing nursing, like everyone in our communities, should have access to these services, not just people who, kind of fit the mold. So I think, that's really what we're looking to do, is figure out how do we provide and how do we get the organizations that are providing these services and mandated to provide these services, how do we create pathways and programs to support their ability to provide care to all individuals. And then, if hospice isn't, something that someone wants to go to, how do we still create that, quality end of life experience and ensure that their end of life, wishes are honored and, that the people they want to, they're in the environment they want to be in and, as comfortable as possible. So how do they get access to a palliative care physician and things like that? And, we're toying with a few models now, while we're looking and evaluating the need, and maybe it is someone who, is there's a model in Sudbury where there's a palliative outreach worker and, she'll go and sit with them, and maybe record their end of life wishes and bring them, whatever it is they need. Is it food? Is it, get the, if they're in a housing unit, go with the nurse, to, who may be uncomfortable, but, go with them and be there while they receive their, their pain medication. So, there's lots of models out there and they're happening in Toronto, they're happening in Sudbury, they're happening all over that we're just trying to figure out, what does that model look like for Grey Bruce and how can we go about implementing it and, getting the service to the people that they really, are, they deserve to have.
I think you raised some really important points, and as you're mentioning, I'm thinking about end of life care in an encampment. I mean, we have people who are intense, and that's assuming they've been diagnosed. That's the other part. We're talking end of life, but it's getting them even where the diagnosis, that early intervention approach. Any surprises from either of you so far about what you've learned or what you've seen or,
Yeah. One thing that I didn't I knew I was going to say casually isn't the word. I knew experientially, or I recognized but didn't know the stats around was how young the average the median age of a homeless person who is passing away. So Toronto has strong data. I don't have the data here for Grey Bruce, but in 2022, the median age of men who were experiencing homelessness who died was 55, and that age was 42 for females. So that is, I think, a really different age and understanding of the people who are needing to access these services. And you do age more rapidly when you're outside. And there is living in not being able to have all of the nutrition and all of the physical protection and all of those pieces, it really does age people more rapidly. And that's something that I am always finding and catching myself on in Safe and Sound when I hear somebody's age, because it's usually younger than I think that they are. And I think that this project's helped me kind of put that into a framework. And as Lindsay was mentioning, there is a lot of different programs around, and I don't think that it's a model probably for Grey Bruce, but Toronto even has a palliative care shelter that has a 4-bed facility. I'm not sure if it's 4 or 5 beds, and one of them is a chronic palliative bed. So and it's specific to people who are homeless. And so I think that there's a lot of important research and knowledge coming from different communities that I'm hoping that this project's able to help leverage.
Thank you for that.
I'll just add to that because I had a really interesting conversation this morning. There's actually an expression of interest out for increasing the number of palliative beds that where hospices can apply for that. And a big portion in the application, I finally reviewed it this morning, is, are you looking to serve equity deserving populations? And I had a conversation and, there's a lot of, I think there's, just because it's something that staff in hospice haven't experienced. There's a lot of kind of, they're just unsure of what that looks like. And I think, this just kind of emphasizes, and it really did for me today, how important education is. And that is a big part of this project as well. We're looking to host a workshop in November, and then hopefully a symposium in the spring, and looking to educate, individuals like who are working on the front line in all different areas, working in Safe and Sound, in the different housing options that we have for people, the emergency shelters, things like that. And just so that they can identify individuals who would do well with a palliative approach to care, but then also for those who are working in hospice to be more comfortable, so that hospice is more of an option for any individuals who would like to go there. So there's really there's a lot of opportunity, I think, that education and kind of some anti-stigma training can help us all in the entire system. So that's another big component of this, and I think a really, really important piece that we hope to really spread throughout Grey Bruce over the course of this project.
You'd mentioned barriers before, so with the population we're discussing today, sometimes there are some additional factors that need to be taken into consideration, including addictions and including some mental health issues. Do you see those as barriers to additional palliative care bed entry or any, because it's part of it's part of who they are. And how do we approach that? And what would be necessary for facilities to be able to accommodate those?
Mm-hmm. I was just, when you were asking that, one thing that I was thinking about is that, like, where is the barrier there? Like, I don't think that the barriers line with the substance use. I think that the barriers line with the institution that can't accommodate somebody's substance use. And so I think that there's an important piece about holding institutions accountable to help them understand that this is something that everybody's growing and learning about. Even just at Safe and Sound, when Safe and Sound started, it did not have a focus on addictions. And what the community has showed us is that we need to smarten up, and we need to be really focusing our resources and understand that this is what the community is asking from us, and to try and meet that moment as best we can.
For sure. Sounds like a lot of learning all the way around and skill development, for sure. Lindsay, any surprises in addition? I know Annette has mentioned anything you've learned so far that you really didn't expect?
I've learned so much. I think, this has been, I feel like I've grown a lot just even in this experience, working with Annette and the rest of the project team. When I started with the OHT and over a year and a half ago, I thought palliative care was hospice. I didn't know what home care really was. And the systems, the complexity of the systems that are currently in place. And I'm constantly surprised by all of the kind of inherent barriers that are like just in the system and accessing care. I don't know how this system's developed to be the way that they are when, they basically don't consider, like, if you don't have a phone, well, all of these systems, there's so many systems that couldn't possibly work for you because you don't have a phone. Or an address. Like it's just it's inherent in the process. So that I'm always kind of shocked by that to some degree. And then I've had the amazing, like really amazing opportunities with this project. We went out to Winnipeg, Dr. Fenn and I, and we got to go visit a shelter there, and I had never been to a shelter before. And this was a shelter where they had something like 150 beds. And they had a clinic there that was staffed fully by in-kind services. They had dentists, they had physicians, they had it was just like, this amazing place. They had a huge kitchen where hundreds of people came every single day to eat. And it was, they had transitional housing. It was just this remarkable place with like the most remarkable staff. And we got to spend a few hours there. And just these experiences have really opened my eyes and made me want to learn even more and just be even more passionate about equity in care. So I think, I think just I'm constantly, surprised, and it just makes me want to learn even more and become more invested in this.
So the system has, in some ways, let those who need this care the most, let them down. But the opportunity to fix the system will exist through this project, and all of the service providers, Safe and Sound, all of the team members. We have a couple of minutes left in the program, so I'm wondering if there's anything you really, really want to share before we have to sign off. I want to invite you both back, because I am inviting you both back. We definitely need to hear more and to learn more. So please come back.
Mm-hmm.
I'm going to turn it over to.
Yeah, I can share a couple different statistics that are current about homelessness in Gray and Bruce, just to kind of give some of our watchers, listeners, some perspective. So current, as of August 31st, there was 218 households experiencing homelessness in Gray Bruce. And out of those 175, it's been over 6 months that they've been homeless in the last year. And out of those, about 56 that they know of are sleeping outside in their car or in a spot that's described as not intended for human habitation. So that's a pretty crushing number. And I think that Safe and Sound, beginning on November 1st, shifts to a 24-hour service model. So we are a drop-in center, and will be a drop-in center instead of just from 9 until 3. It will go 24 hours. And that's a really important, I call it a harm reduction intervention. It's a drop-in is not the dignity that people deserve. People deserve a bed. People deserve their own place to call home. But we have to meet the moment with what we have. And this is what we can do. And so what we're funded to be able to do, I should maybe say. Catch myself there. Where are the barriers? Are they with us? Or are they somewhere else?
And that's helpful. That's helpful. And much as I don't want to cut you off, Annette, I know the producer is going to cut me off in a moment. I think there are so many opportunities for us, all of us as a community together, but especially depending on the wisdom that you bring forward to make a difference. Everyone deserves to live and die with dignity. Thank you both for being on the program, and I do extend the invitation to return, so please. Thank you to our viewing audience for joining us today to learn more about programs, services, and resources for you and your family. Take care and stay safe. Thank you.
Connect with us by visiting our website or email us at comments@rogerstv.com.
Hi, I'm Lynn from Third Eye View, and welcome to a brand new season that we're looking forward to. We have some return guests and some brand new guests. And in the meantime, enjoy the rest of your summer, stay safe.
Everybody knows not to drink and drive, but some people still think it's okay to take drugs and drive. Police have the authority, the ability, and the